Hello everyone and welcome to our module on vaginal cancer. In general, vaginal malignancies are very rare. They're much less common than malignancy involving the cervix or the uterus or the ovary. Basically, for the USMLE Step 1 exam, there are three vaginal malignancies you should be familiar with. I've listed them all on the screen here, and we'll go through each of these in this video now. We'll start with vaginal carcinoma, which is very rare and is usually a squamous cell carcinoma. Just like cervical cancer, it almost always involves human papillomavirus. It has the same risk factors as cervical cancer. And the one thing you want to be aware of for your board exams is that rarely is vaginal carcinoma a primary tumor of the vagina. Most commonly, it's an extension of a cervical carcinoma. So you can basically think of vaginal carcinoma as a carcinoma that comes from the cervix in the majority of cases. It can be primary, but almost always it's an extension of cervical disease. One thing that is high yield to know about the vagina is that the upper and lower vagina have different lymphatic drainage because they derive from different embryologic structures, and this has to do with where cancer tends to spread depending on whether it comes from the upper or lower portion of the vagina. The upper vagina comes from the Mullerian duct, and I discussed this in more detail in the video on genital embryology, and therefore the lymphatic drainage from the upper vagina is the iliac nodes, shown here in green in this picture. The lower vagina, on the other hand, derives from the urogenital sinus, which comes from the cloaca, and therefore the lymphatic drainage of the lower vagina is to the inguinal nodes, shown here in red in this picture. Second vaginal cancer we'll talk about is clear cell carcinoma. This is a rare malignancy that can involve the cervix or the vagina. And the one thing you want to know about this malignancy for step one of your boards is that it's associated with maternal diethylstilbestrol or DES exposure. DES is a non-steroidal estrogen. This is its structure shown on the screen here. It works like an estrogen, but it doesn't have a four-ring steroid structure. And prior to 1971, it was given to pregnant women to prevent miscarriage and premature birth. However, it was taken off the market in 1971 because female babies born to mothers who took DES had reproductive tract abnormalities, and one of those abnormalities was an increased risk for this rare malignancy called clear cell carcinoma. I talk about DES in the video on teratogens, but by way of review, female babies born to mothers who took DES prior to 1971 were often born with an abnormal uterus or cervix. They could have vaginal adenosis, which I'll talk about in a minute, and they were at risk for a rare cancer of the vagina called clear cell adenocarcinoma. In addition, there were high rates of infertility among these female babies of mothers who took DES, and you can imagine that was the case because often their cervix and uterus were not normal. So now let's talk about vaginal adenosis, and once again there's an important tie-in with female genital embryology. So the upper vagina derives from the Mullerian duct and the lower vagina derives from the urogenital sinus. The way this works in utero is that the vagina is initially entirely columnar epithelium. Squamous epithelium from the urogenital sinus then grows upwards and overtakes the columnar epithelium. If a little patch of columnar epithelium is left behind in the vagina, that is called vaginal adenosis. This is the presence of Mullerian tissue in the outer cervix or vagina. Basically, it's columnar epithelium in the vagina where the vagina should be all normal squamous epithelium. This can be asymptomatic, but it can also present as a nodule in the vagina or an area of bleeding in the vagina. But what you want to remember for your boards is that this is associated with in utero DES exposure. So if a mother who has a female baby took DES when she was pregnant, then the baby is at increased risk of adenosis. And there are case reports of adenosis leading to clear cell carcinoma, that rare malignancy also associated with DES exposure. The last tumor we'll talk about is called sarcoma botryoides. It's also called embryonal rhabdomyosarcoma. This is a rare vaginal tumor that occurs in young children. It's usually seen in women, but it can sometimes be seen in boys and present as a paratesticular tumor where the boy develops scrotal or inguinal enlargement. This tumor derives from embryonal rhabdomyoblasts, which are immature muscle cells in the embryo. This tumor presents in children less than 5 years of age. In a board question, it will likely be a female child brought in by her mother because she noticed something on the vagina. It presents as a clear, grape-like mass growing from the vagina. The way it gets its name is that the word botryoid means appearance of a bunch of grapes. And you should Google this tumor right now and get a picture in your mind of what it looks like. Most likely on your board exams, they will simply show you a picture of it and ask you to name the lesion. It can invade the peritoneum and obstruct the bladder, and it's treated with surgery and chemotherapy. Finally, there's a tie-in here with cell biology. In the cell biology video on the cytoskeleton, I talk about desmin, which is a muscle filament. It's part of the Z discs in sarcomeres. This is a sarcomere at the bottom of the screen here, and this is the Z disc, which contains desmin. And desmin can be used as a marker to identify the origin of a tumor, and it's often used as a marker of rhabdomyosarcoma. And 99% of embryonal rhabdomyosarcomas are positive for desmin. In fact, this is one of the ways that pathologists confirm that a biopsy specimen is a rhabdomyosarcoma by staining and seeing if they can identify desmin. So a very high yield fact for you to know about the rare tumor embryonal rhabdomyosarcoma. And that concludes our video on vaginal cancer.